Today we're going to talk about how to make the perfect ostomy. And we're going to go to three things. One, the first three is going to be why it matters, why making a very good one is important to the patient and to you and everybody who takes care of this patient. Where to place it, how to mark your patient, and how to create it perfectly. And we're going to talk about the different types of ostomies. So let's get started. So when talking about an ostomy, it could be an ileostomy or a colostomy. It could be an end or a loop. It is dependent on the type of surgery that is performed. The one thing that is important is you want an ostomy that is brooked so that it actually goes out through the abdominal wall and able to get an appliance on top of it so that it doesn't leak around. How to actually mark your patient. Where should it actually go? So when you're marking a patient, you have to understand what type of ostomy are you placing. Is it going to be a right-sided or a left-sided? Typical left-sided ostomies are going to be an end colostomy after a Hartmann's procedure. A right-sided would be a loop ileostomy, an end ileostomy, depending on what procedure the patient goes. And from there, you can choose which side that you're more likely to place it.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going.
So the first thing you have to understand is where is the patient's belt line? That is important. So we talk about belt line. You don't want to put it on the belt line. So if the patient puts the belt line up here, down here or up here, you don't want to put it down there. You want to put it either below the belt line or above the belt line so that when they're putting their pants on, it's not going to be rubbing against that area. Number two, you don't want it to be on a crease. Because when people have those creases, when you put an ostomy wafer, it's more likely to actually elevate and then leak under. So you don't want it to be on a crease of the patient. So above or below the belt line, not on a crease. The third one is you want to put it through the rectus muscle. Why is that important? When you put it through the rectus muscle of the patient, it's less likely to cause hernia formation. Because if you put it at the edge, it's like giving the patient a Spigelian hernia. Or through your obliques, it's too lateral. It's more likely to widen. And so going through the rectus, you'll have your anterior sheath and posterior sheath, and you have your rectus in between that is split, and that helps hold the ostomy and decrease that risk of formation. So through the rectus. Okay, so now we're going to talk about, we've emphasized why it matters, which is holding an appliance to prevent leakage. So a typical ostomy would look like this. It would be out there. If this is your abdomen and this is your appliance. So you want it to be outpouching. So how do we make an ostomy? The priorities. So the top three priorities is, number one, be able to safely bring out the ostomy. Safely, right? So when you are open or laparoscopic or robotic, you're going to cut the skin. You can incise the subcutaneous tissue. And then personally for me, I actually divide the anterior fascia. So we'll do a cross section of the right rectus. So you have your anterior fascia, your posterior fascia, and then we'll put the rectus muscle here. And so looking at this one, I do a cruciate incision for the anterior rectus. That creates a gap here. And then we split the muscles. You can use Army Navies down here to retract the muscle in between, being careful not to hit your epigastrics. And then you can incise your posterior sheath and peritoneum just vertically. incise it to allow minimum of at least 2 finger breadths is what they say, but for me, it depends on what you're bringing out. If you're bringing out a loop, it's probably going to be bigger, or if there is a lot of inflammation, you may have to extend that. So the priority is to be able to see what you're doing. Meaning, if they're morbidly obese, you may need a larger skin excision and then be able to put retractors deep enough to expose your anterior fascia, do your large cruciate incision, retract your rectus on each side as a muscle splitting technique, and then be able to expose your posterior sheath as you incise it. You have to have that good exposure for control. When you're able to enlarge it enough that you can bring out the ostomy without tension, that is something that is very important, because what you don't want to do is try to pull it hard and then rip and then spill poop all over. That's not a good thing, because that will infect your midline. You could get a deep space infection, and most problematic is if you cause an infection at the ostomy site, then that will cause it to detach and create a complex wound. So really being able to get this out safely is of utmost priority. Number 2, it should be tension-free. So now that you've brought it out, so you have your ostomy here, you brought it out, and this is like an end. And in this aspect, you want to make sure it's actually healthy, that it was not devascularized with enough mesentery. It should actually not retract backwards. For colons, that's very important, because a lot of the complications are secondary to lack of mobilization of the descending colon in a Hartmann's procedure. So if you didn't incise your white line properly, or if you needed to mobilize your splenic flexure and you didn't do that, and if it's still attached to your retroperitoneum and you're stuck, then there's a high likelihood that your ostomy is not going to be able to come out through the abdomen, or it may start sinking and retracting. How much do I want? Personally, between 2 to 3 cm at least. If it's more inflamed, then I want a little bit more, because you need to evert the colon to allow it to brook. And so letting it go and allowing it to maintain there without any retraction gives you a tension-free colostomy. Number 3, and this is something overlooked. When you do this and open it up, you do evert the colon. So when you open up the colostomy, the important thing is you will have to evert the colon. What do I mean? So in this simulation that we actually sutured for our anastomosis, I reopened it, and we're actually going to bring it closer to the camera. This is the serosa and this is the mucosa. And so when you bring out a colostomy, you will need to evert it like that. Pardon the suture from the inside. And so when you evert it, there should be a ratio of the colostomy to the skin opening. What do I mean? Well, imagine if you have such a large opening that it actually is too big when you suture it. Notice how it becomes flattened, but if it's just enough towards this ratio of this colon, notice how it everts, and there would be a ratio for that one. It's going to pouch out. And if it does pouch out, if you look at here, that would be something to allow the appliance, when you place it with a wafer, to provide a good seal so that the poop that comes out slides into the bag and not under the bag itself, and then cause skin disruption, complex wounds, and then disrupt the ostomy appliance in itself. So the third important aspect is creating the good ratio of the skin incision to the ostomy. Okay, so what if we make it too big just to bring out the colostomy because it's so inflamed? Well, you can actually suture the skin closed to decrease the surface area so that when you evert it, it's not going to be stretched out. You want to evert it again to look like this. It's actually... So this is the colon, that's everted, and so you want it to be only up to this area, not stretched out like this, because it's so large of an opening. And so the proper ratio is something that you have to pay attention when you're creating the eversion of the colostomy or the ileostomy. And in ileostomy, it's more important because it's succus that is coming out. So you have to keep that in mind about doing something that's good. So these are the top 3 things: where to actually place your ostomy and how to create it properly so that you get a good Brooke. How do I open my ostomies? Of course, we just cut the staple line if it's an end. Personally, if it's a loop, I prefer to cut it lengthwise on the anti-mesenteric border. Then you can evert it and you can allow it to open and then mature it. The important aspect of that one is if you cut it transverse, if it's very inflamed, the larger incision that you make may end up cutting your ostomy in half. Now you have a double barrel, which is more complex because you've just detached your proximal to your distal. So these are the important things you have to understand when making an ostomy: where to place it, how to do it, and how to take good care of it. If you guys like the video, please click the like and subscribe. And if you have any questions, tips, or tricks, these are things that are based on experience, which I do and have found out to be useful. Type it in the chat and check out our other videos talking about colorectal cancer, and I'll see you guys next time.